Well, good afternoon, everyone. It's a real pleasure to be here with you. As you can see at this meeting, there is a lot of excitement. There's a lot of very interesting developments that we see going on. And as I'll share my story this afternoon, when at the meeting 2 years ago, which really got me started on this latest adventure here, this latest project where we're trying to develop a completely digital treatment concept for full arch implant prosthodontics. So I bring greetings from Seattle and the University of Washington. I've been there since November of 2012, and I'm very much enjoying the opportunities that I've had at the university. So if we look at ourselves as prosthodontists, I started at UCLA, University of California, Los Angeles, in 1984. And there were blade implants, subperiosteal implants, a lot of really bad dentistry. And it was definitely a revolution when Brånemark introduced the end-osseous implant. And so we could take patients who were dental cripples and wore dentures and be able to develop fixed prostheses for these patients that were anchored with screws. And it was it really was a revolution for providing much better treatment for our patients and providing them security and happy. So this we delivered in 1985. 16 years later, the bone is still integrated to the Brånemark implants. Had a little recession, but everything is nice and healthy. So really exciting developments going on with this. And what I would then call the second revolution was that of the development of the concept of immediate loading, first discussed by two individuals, Dennis Tarnow's group when he was at NYU, as well as Paul Schnittman's group at Harvard, which also I think were definitely another revolution that we did not have to wait for the 3 months or 6 months of healing before we could put the patient into a fixed prosthesis. And so where we are today then, with those systems that are working very well, we're now working towards what I call the third revolution in surgical implant prosthodontics here. So we are trying to put everything together to unite all of these digital technologies seamlessly so that they will work together. I want to share just a little bit about my background. From 2009 to 2012, I converted my practice, Pacific Dental Institute, where Professor Dr. Boyer was on sabbatical with us for 6 months. And we changed over to a Clear Choice Dental Implant Center. So we had a focused team. That's all we were doing were implants, oral surgeon, very talented technicians, amazing dental assistants that we put this incredible team together. And we published one paper just looking at the numbers. So this is about 2 3/4 years. We looked at our experience with 474 arches. And this was from day of surgery in the provisional restorations until we were making final impressions. So any failures in that would be what we call early failures. So we utilize the all-on-4 approach. When we didn't have enough security with 4 implants, we had no limits. We would go to 5, 6, 7 if that was necessary, but we'll take a look at these numbers. This is the protocol that we followed, where we would do a complete exam and history and physical workup. We would also then, of course, do a cone beam CT, do a prosthetic workup, and then follow these procedures in terms of the days of surgeries with ostectomy, extractions, implant placement, and abutment placement. And then we would convert these in the laboratory. And in maybe about 3 hours in the afternoon, we'd get these prostheses back from our lab technicians. And we would then do the final delivery and adjustment of that. And then we would make final impressions at 4 months for the mandible and 6 months for the maxilla. We utilize the active and the Brånemark implants. We placed a little over 1,900 implants in this group, utilizing the angled abutments. And so looking at those arches then, 84% of the arches were supported, those immediate provisionals were supported by 4 implants. So it was a technique that worked very well. Whoops, let me go back a little bit. And we had, of those 1,900 implants, we had 11 failures, or about 0.73% failure rate. So we'd like no failures, but I think a very acceptable success rate or failure rate of that. So based on this team approach, which I think is very important, 474 arches and 1,900 implants, we had about a 99% success rate with our implants, and 84% of the time those would be supported by 4 implants. So we have a system that has been demonstrated all over the world that this concept works very well. But there were some things that would take a while. One of those was the amount of laboratory work that was required. It just takes a certain amount of time to pour up the stone, to process the acrylic, to do all the trimming, and do that while the patient is working. So it's great that we're utilizing a concept and systems and have people that are doing great work. But in order for you to be successful in whatever you're doing, whether it's manufacturing or it's your practice, you need to have organized systems. You need to follow standardized processes, and that was one of the things that I think made us successful in these many arches, was that we had an organized system that we followed for each of the steps that we went along in this, whether it was we were just starting and doing the exam and workup, the treatment plan, the laboratory work, then going to the surgical plan, surgery, and prosthodontics, and then ultimately the laboratory conversion I was talking about, the prosthodontics, and then having a very happy patient at the end of the day. So really one of the most rewarding procedures I've ever done in my professional career. So we have a system that works, but again, it's kind of the old school. So in 2013, 2 years ago, I was here at the IDS meeting, and I was walking down the hall, and I almost got whiplash when I saw the 3Shape booth that had this incredible color intraoral scanner. I mean, the detail and the definition of that was incredible. Really exciting. I think almost a quantum leap in what we've had in previous systems, not only the hardware, but the software that makes that work. And then also I had the good fortune, Urs Brodbeck, a guy I've known for too many years to even mention. He dragged me down to Biodenta, a new up-and-coming implant company, but they're much more than that. They're also a completely digital solution company. And in talking with Urs and then Morton and Amir, we found that we were very like-minded, and it kind of got us started on our adventure. And so we started using the Trios intraoral color scanner. I started to use it for smaller fixed prosthodontic procedures. I was very impressed with the accuracy of this. And you can diagnose perio, decay, all sorts of procedures or problems just by the quality of these images. And then allowing us then to do things digitally. And so I again found that the Biodenta folks were very much like-minded, that we think digital dentistry is the future, and I think there's no question about that when you look around what's going on here. And using digital dentistry in all its forms provides predictability, it provides precision, that we can do things much more expediently, simply, and easily, because we know our life as dentists are hard enough there. And so with the development of these various milling machines and what we can do in the kind of occlusal anatomy, for example, I still think it keeps us in the artistry category. We're just using a different medium in terms of how we're doing that. So we put together a development team out in Biodenta, USA, working with Ali Tavazzoli, also known as 7-Eleven. He's always on the phone there, ready to work with you. And Amir and Nicholas, we then put together this team, and then with my new research lab at the University of Washington, we started to then pursue our dream here, and we're definitely on the bleeding edge here of developing a completely digital approach for this. So I developed a research plan to do all this. I'm not going to go into that today, but the one thing I can tell you is in a paper we presented a year and a half ago now, is in looking at the accuracy of the Trios intraoral color scanner for a full arch, that's from second molar to second molar, with a 6-centimeter span between the second molars, there was only about 38 microns of distortion in this dimension, if you will, from second molar to second molar, and then vertically only about 17 microns. So it proved to be a highly accurate system if we want to do full arch scanning with that. So let's then get kind of the more clinical side and then using our technologies. So we're going to talk then about developing this totally digital treatment concept for full arch implant prosthodontics. And what I'd like to try to share with you is kind of a proof of the concept, if you will. We started out working with Jeff, the typodont from CADOA, but then we moved up to Sammy, who is actually a human skull that I bought at 1-800-SKULLS, and that would then allow us to do all the radiographic analysis that we would want to do as well. So this is our volunteer, Sammy. He very much enjoys coming to the dentist's office. We put some gingiva on him, and you can see he's kind of a severe resorption of the maxilla, kind of a class 3 jaw relationship. And now let's think about our goal of developing a completely digital workflow, and we want to seamlessly put together all of these different digital technologies and the software to all make this flow smoothly. Because, you know, a lot of times, maybe you've seen this in your office, you'll have a bunch of different systems, but none of them work together. And so I think that's a very important concept, is to make all these things work together. So we've been talking about dentate patients, patients with teeth. The real challenge for us, though, is how I get from this and go through all of my procedures to be able to get an immediate fixed provisional restoration for an edentulous patient. Now, in order to make that happen in whatever prosthodontic procedure, we have to go through a series of steps. So the first thing we have to do is acquisition, whether that's making conventional impressions, stone models, and working that up, taking pictures, or whether we are doing intraoral scanner. So we're going to do our acquisition of data from a number of different areas and put that together. With that, then we will come up with, if I can change here, is then we're going to put together a diagnosis based on the patient and everything that they're after. And then, excuse me, we're going to utilize these technologies for both the design as well as the manufacturing of each of these components. So our immediate fixed provisional restoration, that's going to be screw retained. Our surgical guide that we need to provide to our surgeons to ensure that we get precision in the placement of the implants and to work with our plan. And then something new that we have introduced is the picking the abutment and then using a guide specifically designed to very, very precisely position those abutments to make all this work. And so we design and manufacture in a number of different ways, but basically the concepts are the same in terms of how we're using these technologies. Why do we want to think about a totally digital treatment concept? For me, one of the biggest things is for our patients. If I can reduce the amount of time my patient has to be in our office by 35%, they're going to be a lot more comfortable. I'm going to be more efficient. I can treat more patients. I can increase the efficiency of my practice and maybe even actually make some money in the dentistry that we are doing. So everybody benefits if we can make this type of a system work there. So we're going to go through those steps that I was talking about. The first one is the acquisition. So you can see here, intraoral scanner, and then a printed model reproduction of that from a digital file that you can have your laboratory do. And we can go ahead and work up all our anatomic analysis on there. And then, as also an important part of our acquisition, is the cone beam CT. We need to then take these DICOM files and be able to put those in that universal language and combine that in our 3Shape software to then go ahead and come up with a treatment plan for what we're going to do, and then go through the sequencing and then have our patients sign off on the treatment that we're going to do. So again, teeth are really not that big of a challenge. We can scan the ridges, as you just saw there, very easily, very quickly. But the rest of the information that we need as prosthodontists is really difficult for an edentulous patient. And I found at my Clear Choice practice, I had to go back to old school impressions, record bases, wax rims, all those things we need to do to find those factors in our patients. So we have all sorts of clinical criteria that we need to somehow get, and really the only way that you can get those types of information, I don't know, is that we need to look at the patient. So we need to capture the face, the lips, the dynamics of how the lips move across those teeth. And until now, we really haven't had a way of capturing that digitally and bringing that to our plate or our table here, if you will, of all of these design factors. But I need to know all of these things in order for me to put the teeth in the right place, to correct the proper horizontal plane, the angulation of the central incisors, and everything else would then follow from that. So we'd like to introduce what we call the CADOA. This is the Computer Assisted Design Orientation Appliance. And we think that with this system, we have something that allows us to bring all of those clinical factors and bring those then into the digital world on here. So you can see that we have essentially record bases here. You can see part of the gingiva, so you can scan those. You can see that we have central incisors. We also then have this on a joint, which allows us then to change the position of the central incisors in all directions to get that right incisal edge position. We have a central bearing point that we can then adjust and determine the vertical dimension of occlusion. And then we can also do a Gothic arch tracing then to determine where the jaw relations and what the centric relation is for that patient. And then we can lock that in. So this can now be fabricated at Biodenta with these, and we're waiting for the patent to come through. Let's look at this applied on our volunteer, on Sammy. So you can see all those elements. So we've got our record base, we've got spheres on here for scanning, a central bearing point, and the central incisors, and we can then go ahead and scan that. So this has been scanned very easily, very rapidly, in about 4 minutes for both arches and then the occlusion. And then brought to the planning source there. So we're going to then go ahead and design our provisional restorations, and we can then take where the centrals are. We can then use the software to go ahead and find the design of the teeth, line up the arches of those teeth with our various points, and now we've improved that even greater with a later version of the 3Shape software, and we can go through the design of the teeth, the location of the abutments, and then of course build up bulk around where the screw axis holes are and where those are going to be surrounding the temporary cylinders. Excuse me. And then we can also go in and design our base material here, ultimately putting all of this together to create the design for our immediate fixed provisional prosthesis. And so then we can even, in this case, what we did is we've lined it up. You can see the seating areas for the standardized metal temporary copings. And we've also then cut it back so we can add pink. We're working on different ways to mill this out. Right now we're kind of doing it by hand till we get further along. So once we know where the teeth are, then we can think about our surgical plan. Do we need to remove bone to make enough space? Implant location, abutments, and the different types that we're going to be using. And so I want to share with you, this is the alpha version. This is the bleeding edge version of the new software from 3Shape. And you can see we are importing our cone beam CT. Let's zoom in a little bit, and you can make out, you can see over here where the CADOA is. You can see the position of the tooth, and we can then start to work excuse me, in the software with our various views. Again, you can see the CADOA in there, and here we have a better view of the bone and of the CADOA in cross-section. And let's just kind of focus on this area. This is kind of the money shot, if you will. So with this, then, I can go ahead and look at where my incisal edge position is. I know where the bone is. I can work on incisal edge position, on the incisor, central incisor location. I can record my vertical dimension of occlusion and my centric relation. I can get all of that, and you can see it here radiographically as well. And then we can go to the design studio and design with our bases in there and proceed on and kind of standard fare for how we position the implants. Again, we're using the tilted implant approach, the all-on-4 approach. We can then design where the anchor pin's going because we want to make a precision surgical guide here so we can get that stable with the anchor pins, and then start to look at our implant locations and then focus in on our abutments, those angled abutments, where we're going to position those. We have, with the biodentist system, we have 18 degrees and 30 degrees to work with and get very specific, but again, very standardized and very controlled data that I have in how I'm going to be designing that. And then from that design, again, we can go to surgical guide design. And here we've developed the design for the pins, the anchor pins in there, as well as the holes and the sleeves, where those are going to go. And here's a then printed guide, if you will, with the anchor pins that have been placed in Sammy, no anesthesia necessary. And then we can have our drilling paths all set up here for depth, as well as our three-dimensional position for our angulation. Right now, we are doing primarily 3D printing. Tomorrow in my presentation, we're going to talk about single teeth, partially dentulous patients, and we'll talk about how you can mill this in your own laboratory or in your own practice. So the important elements, we control, for example, the depth of the twist drill. So we know we go down till this hits on our insertion guide there, and as we then work our way up through larger and larger diameter burrs during the osteotomy. Excuse me. And then we want to get to our prosthetic guide because we want to be pretty precise in how we position our abutments in this. So with this guide then, we can connect the various angled implants, whatever we are, the position of those and the relationship to the implants and to the gingiva, and this will then help us to very precisely position those in there. So these happen to be non-engaging, so we want to be very specific in how we seat these. And then I'm kind of moving around a little bit in the order, but then we can go ahead and mill the provisional restoration. So you saw the seating that we designed. We can also design the screw access holes. And here you can see the seating for the temporary multi-unit abutment cylinders that are going to be placed in there, and the screw access holes. And it's amazing how nice the anatomy is, how smooth the finish, very little polishing is needed. And here we have then related the multi-unit abutments and how those position very nicely into that. And then we ended up adding the pink material on here. So we now have Jeff with a prosthetic screw retained, immediate provisional restoration. And you can see he's a very happy camper. We managed to do some plastic surgery for him. So he has some lips to work with. But again, all milled out of a gradient or layered milling disc on there. And so now he's got the University of Washington spirit, and he's looking pretty cool, and he's happy that he's at least got the upper arch there. So I think we've come a long ways, and I've been showing you the proof of concept here. So now I'd like to share with you where we're actually working on a patient. This is Marina, very sad story. She's 25 years old. She lost all of her teeth about 3 years ago, and she's pretty unhappy, feeling very insecure, self-conscious because she doesn't have any teeth. And so we would like to help her out with that concept. So this is what her ridges look like. So it's great. She's got lots of bone to work with. So that's a nice feature. And we can then intraoral scan with our Trios intraoral color scanner. We produce then our model, our virtual model. We can then go ahead and then design the CADOA to fit specifically to the patient. In this case, we're going to, again, do 3D printing in order to fabricate that. And you can see similar device to what we had for Sammy. So then you can see here we've got our scanning balls, we've got our central incisors, we've got that ball disc and that adjustability that we have for the capture of those incisors. So if I'm doing conventional complete dentures, I make wax rims. I determine where that smile line is going to be. But very importantly, I place the two central incisors, and I have the patient go through their phonetics. The F and the V I want that to touch right at the junction of the wet and dry border of the lip, and I can do that with the central incisors here. I can adjust then my vertical dimension of occlusion till I'm happy with the vertical, and then we can also, again, this is a functional prosthesis as well. So there's forward, back. Now go to the left, and you can see how we're tracking out on there. And so we can go ahead and describe that classic Gothic arch tracing and determine the vertex of that for where we want to capture that. Then we're going to scan. We've already scanned the tissues. Now we scan with the CADOA in place. Again, at our vertical dimension of occlusion. And from there, we can then go to our implant studio to then evaluate the bone. And again, this concept will work well to be able to place tilted implants in here to give her a good anterior-posterior spread. She's only 25 years old. We need these to last for the rest of her life on there. So again, just like with Sammy, we have all these analysis tools at our control. So the only thing now is that we are waiting for the surgery. We're waiting for the completion of a couple small but very important areas from 3Shape in terms of providing some very important software bits in order to make all of this work. So I'd like to thank you for your attention and acknowledge the great work of my colleagues, Ali Tavazzoli, Nicholas Rhoda. We've all had some late nights working together, but really, really exciting to be out on the bleeding edge with the development of these systems, and really, I think, making my dream come true, making it a reality in terms of being able to develop a completely digital approach. If you want to contact me, here's my email address at the University of Washington. I'd like to thank you for your attention. Yeah.